Welcome. My name is David MacLennan. I'm the Chief Executive Officer at the City of Vincent, as well as the West Australian Chair of the WA chapter of the National Regulators Community of Practice. I'd like to begin by acknowledging the traditional owners on the lands on which we meet today, the Whadjuk people of the Noongar Nation, and pay our respects to elders, past and present. It's great to see so many of you here in person, and we also have a diverse audience online from all over the country and New Zealand. I saw somebody has joined us from Malaysia as well. And all of you are working on regulation in one way, shape or form. So we are streaming now live to people across Australia, and we've got a great audience here of West Australian regulators who'll be staying here after the webinar for a networking session and lunch with ANZOG and the NRCoP. A few points about our webinars. They are being recorded. There's a camera up the back, and this recording will be made available on ANZOG's NRCoP YouTube channel. There'll also be some short video snippets available to access on our social media platforms. For those of you online, there is a Q&A function on the Zoom for questions. I really do encourage you to type your questions in, and we'll go into a Q&A session after we hear first from our speakers. If you like the look of someone else's question, you can upvote it on the Zoom function. For those of you in person, we'll be having a Q&A session for all of you after the webinar online session has finished at 12. If you're new to NRCoP, who are we? We are an active network of public sector regulators from all three levels of government in Australia and New Zealand who are keen to learn with and from each other. We support each other to become better regulators and to promote the value of regulation in our society. The Community of Practice started as an informal network of Victorian regulators inspired by Harvard professor Malcolm Sparrow's workshops at the Australia-New Zealand School of Government. I'm particularly pleased that we have Adam Fennessy, the new Dean and CEO of ANZOG, here in WA for the first time since his appointment. Adam, welcome. So ANZOG and NRCoP have played a great role in improving the professionalism and capability of the public sector in how it develops and implements policy and regulation in society. Having an Australian and New Zealand mandate helps provide that perspective of the competitive federalism we have here in Australia and the ability we always have to learn from our close cousins in New Zealand. Western Australia has long worn it as a badge of pride that we won't automatically go along with what might be a Canberra or East Coast consensus on policy or regulation. That does manifest itself on a regular basis through sporadic outbursts on, for instance, the national distribution formula of the GST, WA's domestic gas reservation policy, WA's ban on poker machines in pubs, and of course, daylight saving. And anyone who has arrived at Perth Airport with a piece of fruit in their luggage will also know that we also have very strict state agricultural quarantine laws. And that relates to the fact that for much of WA's history and development, we've been shaped by our geographic isolation. It was long seen to be a competitive disadvantage, despite helping shape an innovative culture and economy. But Western Australia's geographic isolation did become one of our greatest advantages during COVID. So I'd like to take you back to the start of 2020 and ask, can you remember the first time that you heard about coronavirus? Was it on the news, from a friend, family, or a colleague? And do you remember your first thoughts, reactions, feelings, or emotions about this new strange virus? And then can you also remember how you felt about the reaction from federal, state, and local governments as the global pandemic arrived here in the country? COVID-19 was a global crisis which forced a coming together of Australia's public service and public institutions at federal, state, local levels with the private sector that has never occurred in this country outside of wartime. And to some extent, the arrival of coronavirus mirrored that of an invasion of an external threat to the entire population. The difference being that this threat was invisible. And it was certainly different in scale to previous outbreaks around the world of bird flu, swine flu, Ebola and Zika virus. And it's different in the significance for the potential threat to the Australian population. But it was our public health experts which led the response to this threat. And our political leaders depended on their advice in the same way they depend on military advice in wartime. The WA response to COVID-19 in 2020 and 2021 enabled WA to largely prevent the introduction of COVID-19 into this state while rapidly managing and eliminating the spread from the small Alpha and Delta outbreaks of COVID-19 that did occur. This was a careful calibration of restrictions balancing the public health risk, the need to support the economy, and to roll out those miraculous vaccinations. I'm very pleased that today we have three of our most preeminent public health experts. Dr. Andy Robertson, the Chief Health Officer of WA, Dr. Kerryn Coleman, the Chief Health Officer of the Australian Capital Territory, and Professor Tarun Weeramanthri. They'll be speaking about the decision-making process, the risk assessments and judgments involved in Australia's COVID-19 response. We're well aware that COVID-19 is still with us, but we have been able to manage very well in comparison to most other countries. Andy, Kerryn and Tarun are all going to speak for around 8 minutes, and then will be followed by a Q&A session with our online audience. And first, Dr. Andrew Robertson is the Assistant Director General and Chief Health Officer within the Public and Aboriginal Health Division of the Western Australian Department of Public Health. With specialist qualifications in public health medicine and medical administration, he served with the Royal Australian Navy from 1984 until 2003. Since 2003, his role as Director, Disaster Management in WA Health, he has been involved in preparing for and managing health responses to a range of state and international disasters, including the Asian tsunami, Java earthquake, Nepal earthquake, and local cyclones, bushfires, and heat waves. He's been undertaking his role since June 2018, including the WA health response to the COVID-19 outbreak. Andy, welcome. Thank you.
Good morning, everyone. I'd also like to acknowledge the country we're meeting on today of the Whadjuk people of the Noongar Nation, and to pay my respects to the elders past, present and emerging. So one of the challenges I was asked to just have a little bit at is what was unique about our approach to this pandemic. As regulators, and I'll go into that in some detail, but as David has said, we were in a somewhat unique geographical position. It's a bit similar to Tasmania. We actually were able to control our borders, which is something that unfortunately a number of other jurisdictions were not able to do, and that put us in a good position. That was obviously accompanied by the decisions at the time by the Commonwealth to restrict international access. That obviously required quite a bit of work from us in the hotel quarantine space, which is an area as a health practitioners we hadn't ever got involved in the past, and probably in no hurry to get involved in again in the future. But it was an important aspect of it. The other aspect was that we were able to control, and using our contact traces and our quarantine and isolation requirements, both detect, control, and certainly with the case with both the Alpha and the Delta outbreaks, basically eliminate them in WA. So what that meant, and this was unique for us, is that during that 2-year period between, from the first outbreak in March 2020, and once we got through that outbreak, we were basically able to maintain society operating as near normal as could be, and probably closer to normal than almost any other jurisdiction in Australia and certainly around the world. So that was a bit of a unique thing. And the WA population, I think, stepped up to address that. So there were the few internal restrictions. The other thing that was unique is that we managed to buy ourselves time. And by doing this, and appreciate that obviously the border controls did have a major impact on travel across the borders, and that obviously comes with its own pressures and problems. But what we did do is, by the time that we made the decision to open the borders on March the 5th this year, we had a population that was already 80% booster dosed on their third dose. And that actually really prepared us well when we went into the Omicron wave. We knew that we couldn't control the Omicron wave, that we would get outbreaks, but we probably believed that, better than almost any other jurisdiction, that we were in a good place. That's unfortunately, as we know, that has led to, quite a lot of disease. We're still seeing it playing out in a third wave at the moment, but it has fortunately, our death rates are half of what every other jurisdiction in Australia. And that has, that I think has been no small point to, one, being able to keep out some of the Alpha and Delta, which were quite, were probably very nasty variants, but also a good vaccination rate going forward. As a regulator, this was a bit unique. So there's a couple of things that were unique in this particular setting. One, we had 2 acts that were running together. So it wasn't just about implementing the Public Health Act or implementing the Emergency Management Act. We had to find that basis of working together, utilising both the acts. And the acts were, the Public Health Act, as people know, is 2016. It's pretty recent, so it had quite a useful act. But neither of acts had ever invoked their states of emergency before. So this was something that we had never seen before, and we'd never seen many of the things that came out of it. The directions to people to do or not do something had never actually been done in anger, so to say, before. So we had to work very closely, particularly with WA Police, where the State Emergency Coordinator, who is also the Commissioner of Police, there was that requirement to work very closely together. And that actually worked well. But there are some vagaries of the acts. People have sort of said, well, why didn't you just do it under the Public Health Act? Why was it, or for that matter, under the EM Act? Under the Public Health Act, we can't direct police. So police obviously have a very critical role in compliance and enforcement. Whether it's sitting on the border at Eucla and making sure people have actually got the right papers to come across, whether it is, chasing somebody who has decided that escaping from quarantine is a good idea. All of that required our collaboration together. But it did work well, and I think we've seen it play out over the last 2.5 years. So what did we learn? There are, as regulators, we discovered that the Act obviously, whilst developed, and the challenge with applying any Act is there were some oddities within the Act. And we had to use EM Act, for example, for quarantine. Under the Public Health Act, I can quarantine people, but I have to check on them every 24 hours and provide a report on them every 24 hours. Doing that for 5,000 people a day was never going to work. So we actually had to do it under other acts. But there were obviously benefits, for example, on preventing access to hospitals or into aged care facilities where there was a mandatory vaccination requirement, and that was more easily done under the Public Health Act. So as regulators, we had to control exactly what we were doing. But it did work well together as a mix. Do we need to refine some of the acts? Look, we do. There is quite some duplication between the two. But I suppose one of the things we did discover is that there was sufficient flexibility within those two acts to allow us to implement the public health and social measures, the isolation and quarantine, the testing requirements that we needed to do. And while we will probably review the Public Health Act and the EM Acts now to implement some of those benefits that we've identified, we don't want to lose that flexibility that allows us to address what's happening on the ground, operational things. And that was obviously varied from everything from cruise ships to border controls, and we need to continue that. But I'll stop at that point, thank you, and hand back to David.
Thank you, Andy. Our next speaker is Dr. Kerryn Coleman. Kerryn is the ACT's Chief Health Officer and was appointed to the role in December 2019. Dr. Coleman leads the Population Health Division within the Australian Capital Territory Health Directorate, which provides a range of services and programs aimed at improving the health of the ACT population through interventions which promote behaviour changes to reduce susceptibility to illness, alter the ACT environment to promote the health of the population, and undertake interventions that remove or mitigate population health hazards. Kerryn has also worked across several Australian states and territories, including here in WA, the Northern Territory and Queensland, where she led a regional public health unit with responsibilities covering a large area in the central part of the state. She has also contributed at a national level for almost 6 years in a variety of public health roles within the Commonwealth Department of Health. Kerryn, welcome.
Good morning, everybody, and thank you so much for the invitation to be here today. It's actually giving me a real opportunity to reflect on the last 2.5 years, and I don't think, Andy, we've really had the opportunity to stop and do that as much as we would have liked. For me, when I first got this job in December 2019, I actually thought of myself very much as a baby Chief Health Officer, and I still think I'm the baby cho on the AHPPC. So it was the very first time that at a state level I'd led a health systems response or had a leadership role. So my reflections today are probably going to be a little bit of a contrast to what Andy's been talking about. So I'm going to talk a little bit more about those reflections for myself on how we did things and what was important in that way. For a jurisdiction that couldn't be more of a contrast to what Andy's just described in WA, which is dear to my heart because I'm actually born and bred here, so my family's still here, so I know both of them really, really well. The ACT is a really small jurisdiction. We have a small geography and we have a small cohort of people there, but we have a very, very literate population who has very, very high demands, and they demand a lot from government. We're an island in New South Wales, literally an island in New South Wales. We're also the seat of the Commonwealth Parliament, and I'll just reflect on the challenges of both of those as we progress through the pandemic. The really good news was we have very limited international airport capability, so thank God at the start we didn't actually have to stand up too much in the way of international border receipt and any hotel quarantine at that point. We have one tier of government, which has its really good benefits in terms of a consistent and cohesive regulatory and compliance effect. But one of the challenges about that is that our government and our ministers are extremely close to our community. That's across the board. So the good thing about that, but also the challenge about that, was that we really had the authority and the expectation that our response would be community focused. So I guess this played out in a number of ways for us from the very beginning. And I didn't really realise that this is what we were doing when we were doing it, so it's good to reflect back on it. I think that what we developed was a really integrated and holistic approach to our policy cycle that actually involved all aspects of that really quickly, just by instinct, because that's kind of what we do day to day, very much so. And when you're in a small jurisdiction, it's quite easy to do that. Well, I won't say anything was easy during the pandemic, but it is quite easy to do that because you have all the right people really at your fingertips to do that. So how did our ACT community-focused response played out? It meant that we had support from our government for home quarantine instead of hotel quarantine where it was possible. So our models were quite different. We invested very early in a lot of the wellbeing supports and home supports that we needed. That was really useful for cooperation and compliance perspectives, but also in working through with our vulnerable cohorts. We had NGO liaison officers embedded in our response so that we could ensure that there was a really good mechanism in which we could develop our policy but also run our operational response. But we were also really, really responsive to community concerns and issues. And I think one of the things we spent a lot of time on was getting a shared understanding of what the intent was. So this went right through to ministerial discussions in Cabinet, right through to discussions across our cross-government collaborators, and then right through to our comms, our regulators, our cooperation officers, all of those kinds of things. In terms of as long as we understood what our shared intent was, everything really flowed from that with a two-way communication. How did we actually do that then? We were very lucky. We only stood up the Public Health Emergency Act, so we didn't have two acts running, which actually gave me really good control. I had to treat that with a lot of respect. There was a lot of conversations in collaboration with the Health Minister and our Chief Minister, but we were lock-hip together in our, I don't know if any of you saw when we actually stood up and were doing our daily presses, but there was consistency in government message from both myself and Health Minister and Chief Minister, and we worked very, very hard at that. To help us inform that, we actually set up a regulatory and compliance working group which reported to me and was led by our health regulator. That had membership at senior levels from all of our regulatory agencies. It had comms membership, it had operations membership, and it also had policy membership from the guys who were developing our directions and all of that kind of stuff. I mean, that was a nightmare. These went for 20 hours because you had to develop these directions and responses very, very quickly. But it gave the opportunity for us to identify what those issues were early in the development, coming from the guys who were going to be on the ground. Could we deal with them in our direction, or did we have to deal with them in our communications? So in that way, we actually managed to get some of the really obvious things fixed really early in the cycle. The second thing we did was we actually had what we called a communications inquiry working group. These were the guys who were essential to actually ensuring that we had a consistent response across government for all of those community questions, industry questions, business questions. So we had many ways in which community could come in through our on-the-ground offices, through a COVID hotline, but we also had an email way in which we could do that. Those guys met every day, they were moving through those, and that was filtering in a two-way way into our communication and our forums for our outward visibility. I think the other piece of work that we did to support our officers was to develop a framework from compliance and regulation, and that was really clear on expressing our intent and our posture, so that in that way we could communicate the fact that we were being very community driven and orientated, and that this was the reason and purpose for what we were doing. And while we were less prescriptive than potentially other jurisdictions in terms of how our compliance rolled out, it's possible in a small jurisdiction to do that, and our officers are used to working in a way with community, which is really, really nice. But did it hold up as the pandemic progressed? Because it went for a bloody long time and we all got really tired. Oh no, and I think sustainability is a really, really big issue here. Yes, it did, but we did have to really use some of those templates carefully. The two biggest pressures that came for us was when we started to look domestically as our risks came due to domestic transmission, what the hell did we do with New South Wales? Like New South Wales had outbreaks, we had a porous border, we had people who literally lived across the border. We had to develop such a close working relationship to actually make sure that our rules and our communications were consistent, because confusion and inconsistency really, really destroyed trust in what we were doing. So we really, really had to do that. The second one was those damn Commonwealth parliamentarians. They wanted to come in and they wanted to meet in the national capital. Parliament House itself does not actually our laws don't apply in Parliament House. However, they wanted to actually respect our laws but still be allowed to do what they wanted. So there was much back and forth with our Commonwealth parliamentarians. And one of the things that really concerned me about that was the modelling effort. We really need our leaders to stand up and model the behaviours that we need to model moving forwards. And I think there was some challenges in that space, but I won't say anything further about that. Hopefully we'll get a chance to talk a little bit about trust and those kinds of factors in terms of people coming along with us as we go, because my 8 minutes has gone much more quickly than I thought. But thank you for the opportunity.
Thanks, Kerryn. When we turn off the webinar and our online audience and the cameras and the recording, maybe you can share some more of those stories about managing the federal parliament during that time. Professor Tarun Weeramanthri is President of the Public Health Association of Australia and an adjunct professor in the School of Population and Global Health at the University of Western Australia. He is a trained specialist in internal medicine and public health and has a PhD in social medicine. He was Chief Health Officer in Western Australia from 2008 to 2018, and previously in the Northern Territory from 2004 to 2007. Tarun oversaw the introduction of the WA Public Health Act 2016. In 2014, he was awarded the Sydney Sachs Medal by the Public Health Association of Australia for his contribution to public health nationally. And in 2022, he was made a member of the Order of Australia for service to public health administration. And over the last few years, he has focused on addressing the health impacts of climate change and assisting the COVID-19 response in various Australian states and nationally. Welcome, Tarun.
Thanks, David. Good morning, everyone, and online. Can I join my acknowledgement of country to the acknowledgements already made? It's great to be in a community of regulators. I still care very much about good regulation, and I think everyone here does the same. Why? Why do we care? The best one-liner I've ever heard is that law is for everyone, not everyone else. And that's that sense of fairness, that we all have to be treated equally by the law. And we see examples where that's not the case every day and read about them. I was struck by the title of the word legitimacy in the title of this seminar. I've thought a lot about trust in government and trust in regulation, but I don't think I've ever thought about legitimacy. Clearly, we have a system. We all have to do our jobs as regulators seriously and dutifully. And I always felt that if you did that, you know, people may disagree with your decisions, but if you communicated it well and explained it, you'd maintain the trust in the decision-making process. And accountability and transparency are crucial to maintaining trust. But I do think there is a legitimacy issue now, at the end of 3 years of the COVID pandemic, that we've rarely faced before, and which we as regulators will need to think about in the next few years. And the difference between trust and legitimacy, I've not looked this up, but I've just thought about it in the last couple of days, is it's about system legitimacy. You may disagree or distrust or individual decision makers, but when the public starts to question the legitimacy of the whole system, we're in a different ballpark. And I think that's the case at the moment. So we have seen that that there have been recent high-level decisions and which have been subject to royal commissions just finished or inquiries just finished and current, which really do, as a member of the public, make you think, is the whole system legit? Because there's some things you shouldn't have to regulate, right? Some things you shouldn't have to legislate. The idea that you've got to write down for a federal minister the fact that you have to publish ministerial appointments in officially, you shouldn't have to tell anyone that. And so where are we at if we have to go to that point? Because you should understand the system if you're part of it. It should be part of your ethics. It should be part of your training. It should be part of your responsibility to do the right thing, the ethics of it, as well as just because the law is written there. So the regulatory approach is very different to simply applying the law as it is written. We know that we have to go back to the intent, as Kerryn has said, and we go back to second reading speeches, we go back to all sorts of things to understand the intent of the Parliament in making various laws that we then have to apply. But we also then have to work with the public and do that communication. And it is an art. And there are issues about timing and proportionality, etc., which are completely salient. When you look at the Public Health Act, there are principles built into the Public Health Act. The most obvious ones, which we always use, is the precautionary principle and proportionality. So I won't go into those. But there's a couple of other principles which I've always struggled with, trying to work out what they actually mean. And I think I understand it a little bit more now. The first is sustainability, which is not actually about environmental sustainability. It's actually about long-term community benefit. So this is written into the Public Health Act. The second is intergenerational equity. So that's, and the last actually, relevant to today, is the role of local government. So these principles are what we work with, as well as the wording of specific provisions in the Act. We work with the norms that are in society in terms of how we apply them and how we enforce regulation. And so, I can't imagine how many conversations Kerryn and Andy have had in light of that with their fellow regulators. And of course, we work with other acts, other players. There is a line between experts and decision makers, but I don't think it's the line that people have portrayed. Of course, there's a role for expert advice, but experts should never be simply the decision makers. Otherwise, you've got the benign bureaucracy of just kind of making all the decisions. And I never wanted that as a public health official. I just wanted to be listened to, the arguments to be time to put the arguments, and the elected representatives should then make the decisions. So it was a bit of fiction right at the beginning for the public to say we've listened to the experts and we've just made the decisions. And over time that broke down, and appropriately so, because it should be up to elected people to get a variety of opinions and then make a decision. And some of the decisions the politicians made were against public health advice and were right. So the initial decisions around closing the borders, etc., were not provided by any public health expert committee. And the politicians, though, did make that decision, and over time we've had to rethink our public health advice globally, because we always said you never shut borders, it's a really terrible thing to do. Okay. There's one point about transparency that I'd like to make, which is that transparency isn't just about knowing who the expert committees are and knowing what the decisions have been made. It's also fundamentally about transparency of process. I struggled to make it. I tried to make this point multiple times, and I kind of gave up because no one gets it. When you're interviewed on the radio, people just want your opinion. Okay, they just want to know, should this be done? Should you have this or that? But you just get a multitude of opinions. That's all you get. And I just add my voice, and who cares really what I think, because someone else can come on 5 minutes later. What I care about as a member of the public is that there are good experts in place, that they've been selected widely, that there's some kind of proper process whereby they get to develop a consensus view, that it's given to government who consider it carefully. Okay. So I want to know about the process. What I saw was, and I am being slightly critical here, which is over time, especially because this was a long-running event, what went on behind the scenes became increasingly opaque to me for someone who really cares about these things. And the best analogy I can make is that is a food inspector. A food inspector has to be able to go into the kitchen, has to be able to look around the kitchen and see who's doing what, how the food's being prepared, etc., the state of the kitchen. They can't sit in the restaurant and have food being brought to them and saying, oh, that tastes nice, therefore there can be no problems. And as a member of the public, I was kind of felt that in that situation. We were reassured that there were chefs in the kitchen. We were reassured that the food coming out was terrific and we knew what the menu was, but there was no ability to go behind the scenes with people explaining how those expert processes were working, especially when there was such a diversity of expert views. So I'm very glad that people, who I respect highly, and experts committees, etc., who I, again, respect highly, work so hard to provide this basis of trust and advice to government. But I do think there are some longer term issues, partly because simply of the length that this pandemic went on, which has led to some fundamental shifts in how the public views government and regulators. And that's the challenge for us going forward, is to defend the legitimacy of the system as much as we hope in the short term to earn people's trust. Thank you.
Thanks so much, Andy, Kerryn and Tarun. I'm going straight to the online questions. So for our online audience on the webinar, please start typing or upvoting the questions you'd like. And the first is from Kevin Taylor, and it's directed to Andy. Did WA Health learn anything from the Ruby Princess that assisted in the management of the cruise vessel Artania? They obviously had very different outcomes.
The simple answer is yes, we did. Obviously, that was one of the first indicators. I'd have to make a point that we'd already had some experience. We'd already deployed people up to the Diamond Princess up in Japan, so we'd already had some experience of managing outbreaks on board ships. So the Ruby Princess was probably just a confirming one for us. And there were approaches to how we manage cruise ships that were being developed at that time. So it was an evolving process. And the release of people into the community, we obviously, particularly when we were in the process of closing borders, and how quickly they could spread through the community was something that we learned. When we then went on to manage we had 3 subsequent cruise ships, and the most notable of which was the Artania. We actually did a very different approach, which was more around managing the outbreaks on board, and obviously bringing off those people who needed appropriate medical care, noting that many of them had relatively mild disease. So it did help guide us going forward. But I think we also learnt that it was an evolving and rapidly evolving situation, and it would have been a very hard decision to make at the time from New South Wales government.
Another question, probably for all panellists, about the entire health system. What changes need to be made to regulatory structures to enable the health workforce to respond to future health crises in an agile way? Kerryn, I might start with you. It's been a massive staffing, personnel issue around our skills and how we run hospitals and other health services.
That's a really big question, and I still don't feel like a confident regulator at all. So I'm not going to try and answer that specifically, but I do think we need to spend some time on potentially doing what we call our little after action or our big reviews of actually what are the questions that we want to answer, and then did we learn anything that we would like to integrate better into that. But the 2 guys flanking me have been in the system a lot longer than me, so they might have some specific stuff. Shall I go to Tarun, or you ready?
I'll go to Tarun. I'm going to give Andy, you've got another one.
Thanks, it is a huge question. So there's a lot of people in health who don't appreciate how much regulation there is around their daily work. So I had a couple of senior exec colleagues say to me at one point, do we have regulation? They're hospital execs. They kind of didn't know that we did regulation, right? And so it made me scratch my head. But I think the invisibility of that regulatory framework is more obvious now. I think it's hard to think about it for me in terms of hospitals. It's easier in terms of aged care. And I think we should potentially start, because we all understand and can see aged care either as users of the system or as carers or whatever. And I think the need for good regulation in aged care is so obvious, even more obvious now. And then you need to then try and take it over into the hospital and healthcare sector. Thank you.
For me, looking at the regulation, one of the challenges we had was having the appropriate workforce, whether that be our vaccinators, whether it be nurses working in remote communities, all of those. And one of the issues as regulators that we need to look at is scope of practice. We very much often talk that pharmacists can't do this, nurses can't do that, but we use lay vaccinators. We use people from the general public who were taught how to stick a needle in the arm. They were supervised by appropriately trained personnel, and we have to seriously make sure that we don't place as regulators barriers in the place that enable us to do that going forward. Because many of the roles that needed to be done could be done by people other than doctors, nurses, and allied health practitioners. So we do need to look at how we actually deliver the care. The other thing was workforce. The public health workforce was probably underdone, and there's no doubt about that. And when we went out and said we need more public health nurses and physicians and everything else, the cupboard was a bit bare. And we were grateful for all of those people who stepped up. And we've got a number of very good registrars that have come out of it. But it is something we do need to continue to look at, because there are those necessary skills that we haven't really encouraged, or we've tried to, but haven't had much uptake from governments in the past, that we need to continue to develop those skills, because they do become critical in these kind of settings.
Just a follow-up question, Andy, on that from the online audience. What protocols should be developed in collaboration with governmental and non-governmental stakeholders to enable workforce surge capacity as part of broader disaster management plans, and what changes would help?
So again, it's a fairly complex question. I think the scope of practice remains an important thing. I think we fortunately have the legislation that allows us in a disaster to do a lot of that. But the issue comes when we're in a pandemic with a state of emergency. There are a lot of powers that sit underneath those acts, and we can do a lot of this through those sort of rings. But if we have another disaster, we have a cyclone next week, and I'm not predicting, but if we had a cyclone next week and we needed additional personnel, how do we actually get additional health personnel, enable them to have the necessary cover? Because part of it is about both protecting the patients that we're managing, but also protecting the staff, to make sure that we don't place them in positions where they're not trained for it and they really are out of their depth. And that doesn't help either staff or personnel. So it is really around how we are able to facilitate that. But Tarun or Kerryn may have other comments.
Another question. We do have representatives from Aboriginal controlled health organisations here, and there was a great concern about the vulnerability of our Aboriginal population against COVID-19, both in the city and also in remote and regional areas. Tarun, could I start with you on your thoughts on whether we got that right?
So I think the success of the response to Aboriginal communities has been widely discussed, and the fact that the Aboriginal community-controlled health sector led that response for their communities should be continue to be acknowledged. In terms of the regulatory piece, it was a very interesting piece in WA, as Andy would remember. I saw it a little bit. I was working in Department of Premier and Cabinet, and just the level of regulatory expertise knitting together the Biosecurity Act, the Commonwealth Biosecurity Act and the State Act in order to allow local communities to put up borders and prevent entry of people into remote parts of WA was an incredibly technical regulatory piece which had very, very good outcomes, underpinned by good community engagement and a strong sense of purpose. But one of the reasons regulators are so respected is because they attend to detail, and it was really needed.
Kerryn, any thoughts on Aboriginal and Indigenous populations?
Is this on? So I'm going to use, you can use yours, I'll use Tarun's. Thank you. So I worked in the Commonwealth in the Office of Health Protection during the H1N1, and we were certainly not so successful during that time, but much of what was implemented this time around was very much built on the lessons and the things that we put in place back then. So I think I think the response this time was excellent. I think there's always room for improvement, but those changes we made around governance and ensuring representation right from the top through to the bottom really, really played out well. But also I think we've done a lot of work locally in each jurisdiction in terms of embedding those processes and the ability to engage both at an operational as well as a decision-making level. So I just think the system has matured in that way to such a degree that it really played out. We need to just replicate those for all of our more vulnerable communities across the board, which creates that complexity. But I think we should be proud of that response with our colleagues. Thanks. Oh, you've got one.
Look, I think Tarun and Kerryn have addressed it quite well. I think it was around that early and I think comprehensive engagement with those communities through the community-controlled health organisations, and listening to the concerns that were raised and addressing those concerns. And we did have a good outcome. There were, and to a degree, we were also fortunate that because we hadn't had those outbreaks, the Alpha and Delta outbreaks, and we'd seen how those had been managed in different jurisdictions, there were lessons that were learned from the other jurisdictions about what had worked and more critically, what hadn't worked. And we were able to, I think, that enabled us to use those lessons and to hopefully to steer our response in a fairly collaborative way. So I think it was a good outcome going forward.
We have a few communications officers online and in the room, and public communications were critical throughout the pandemic. Kerryn, you touched on that in terms of the daily media conferences, and Andy, I'm not sure if you've counted how many media conferences you attended. The question is, what were your key learnings about how we communicated the risks and the need for restrictions, including lockdowns, during this time? Noting also, I remember our communication staff in local government were working 24 hours a day, and in state government and federal government it was a huge communications exercise as well as a health exercise.
I might start. Look, I think the thing that I learned is the real importance, particularly with the announcement of major decisions or major changes of policy, of having the public health input. Having both myself and in our case the State Emergency Coordinator there to actually address the sort of the advice behind whatever the policy change had been, and to be able there to answer the questions. The comms, there was that and we still get it. I still get regular requests for information to hear from the Chief Health Officer, hear from the State Emergency Coordinator, because the population was keen to get that. There is always a perception about the politicians and that they have a particular position, but they wanted, I suppose, to a degree, confirmation that this was also truly reflective of the advice that was being provided. And that was important for us to be out doing that. Message didn't always get across, and sometimes it was perceived as mixed messaging, but look, generally I think it worked well. There's always ways to improve.
So this was my first experience being so open and in front of the camera to a community. What I learnt was that honesty, both in actions as well in what you say, as well in body language, is probably the thing that got me through. And I hate this word because it's such a cliche, but authenticity in being able to be part of what is happening as well as leading what is happening. I think we all know that it is really complex to talk about risk, particularly in this situation when there was so much uncertainty. But we just have to continue to improve at that, and we have to continue to include our communicators in that space to assist us in presenting that. We didn't do that very well, and I don't think we did that consistently. One of the things that I think we did really badly as a nation, probably no any worse than any other country, was as we progressed and there were different responses across the nation, we lacked consistency. And I think consistency undermines trust. So poor consistency, lack of consistency undermines trust in your message. And I think that we need to be better at how do we acknowledge that there needs to be differences while retaining people's trust in the decisions that are being made that reflect different contexts. I don't have the answer.
Tarun, your observations about how the different states communicated this at the Commonwealth level as well?
Yeah, no, so I think Kerryn's made that point around consistency, but there's also another time dimension, which is this went on for a long time. At the beginning of the pandemic, at the beginning of any crisis, there's always those, three elements of threat, uncertainty, and urgency. So that's what characterises a crisis. And people get that at the beginning. And you expect most crises to last a few days or a few months at the most. And the communicative practice of the Premier and the Chief Health Officer standing up and giving a single message, it works really well because people want to trust government and they get why these restrictions have to be introduced. What was so difficult here was not only is in any outbreak, it's always harder to manage the downside, the opening up, after you've reached the peak of the outbreak, because you've then there's a whole lot of judgments you've got to make about the speed of opening up, etc., and scaling back off the response. It's easy to scale up, really difficult to scale back and know the timing, and really difficult to communicate that to people around why those decisions are being made and why you're going slower or faster than someone else. But made even more complicated this time with the subsequent waves. So it's not just over, but it could come back. And the point I'd make is I think the communicative practice didn't evolve over time. And people were still using the same daily press conferences, a couple of spokespeople for way too long. And the public kind of turned off. And there wasn't an ability to then switch the messaging up.
Thanks, Tarun. A question from Lynn for all panellists. Hindsight is a wonderful thing, but looking back, is there anything you would have done differently, and what were the key lessons learnt? Anyone want to go first on that one?
I'll make some comments. Look, the issue probably here is that, yeah, hindsight, we always have 20/20 hindsight, we always look back. There were things that we would have done differently, if we had known the situation at the time. I think about the use of masks. Some of the initial advice was, you don't need to wear masks. That was probably, an early, really a misunderstanding of the disease and the real benefits for wearing masks. And that changed over time appropriately. But so there are lessons that we learnt as we came along the way, and there were things, and there were decisions that we made that probably in retrospect we wouldn't have made. I don't know if people remembered that we locked down all of the gun shops for about 2 months here.
Did you?
Yes, we did, and that caused a little bit of angst at the time. But it was, it was probably not. From a public health point of view, it was more of an emergency management decision. But it was, you sort of go back and think, was that really the right decision at the time? So there are always going to be things like that we didn't do. But I think overall that we were, the decision making did work. I will take up Tarun's point though. It's been far harder to, once we have moved past the first wave and we are now in this phase of having, subsequent the BA4-5 outbreaks, this subsequent outbreak that we're having at the moment, and to try and manage that going through, particularly now where there are no states of emergency in place anywhere in the country. So there, not only, but that also means that there are also limitations on what can be done and having to do it within policy. And that doesn't mean we can't do it within our own settings, for example, within our hospitals, but it is more limited what can be done beyond, good public health messaging as to what we can do without the government's feeling that this is the right step to go forward. So it is a challenge, and I'm not sure, I think, that any of us realised how difficult this phase, and there's also the drawdown of people and staff and equipment and everything else, and how difficult that is to manage when largely society, governments have moved on to other things, and we still need to maintain some capacity while appreciating that there are other priorities.
Thanks, and I'll take the lessons learned question as our wrap-up question for our online audience as well. Kerryn.
So just reflecting on what Andy said, I've got 3 things that I would comment on. The first one is other people in areas might have done this, but I need a framework or some way in which I can consider the multiple aspects in making a decision about public health. So by that, I mean we are well trained around the public health aspects of that, the evidence of that, all the kinds of things and the responses that we've done. We also know that we need to think about the socioeconomic, financial, all of that kind of stuff, but there was no explicit, going back to Tarun's, which made me thinking that we don't have an explicit way in which we can actually prove or show that we've considered those impacts across the board. So anticipate lockdown will have this impact. How can we consider that, and how does that flow into our decision making? I think if we could have something that assisted us in both doing that as well as communicating that, that would be really, really helpful. I think I'd be a bit more, or advocate for being a bit more explicit about how we communicated risk and response from a community perspective versus a healthcare perspective. I think we got quite confused sometimes, and I think masks and PPE has played that out. We should have set those boundaries right at the start, and we should have been consistent around those. And finally, I think I would do something earlier for myself and my staff in terms of wellbeing and support and sustainability for those senior leadership teams, who I think that we are really going to have significant challenges over the next couple of years as people reach their absolute beyond limits. and that goes to the workforce issue for those core competencies. Thank you.
Thanks. Tarun, you're going to get our...
20 seconds?
No, you've got a couple of minutes. You're going to get our last word, though, for our online audience on the webinar.
Okay, thank you. So great discussion this morning. So public health, one of the words is public. Probably haven't talked enough about that. And public health is as much part of public policy as it is part of health. And so this regulatory framework is really, really important as a general public policy principle. But behind that sits our constitution and our federation. And we have to get back to the basics of that. And the best example of how we forgot that was National Cabinet. I think 3/4 of the people in this room would have had the same reaction I did, which is this is much more a COAG replacement and is extra constitutional. It's not part of our constitutional structure to have a National Cabinet. There is no historical precedent. The Advisory War Council in the Second World War was not a precedent for this. There was no basis for thinking this was any kind of cabinet at all, and the High Court found that, and you could have worked that out right from the beginning. Yet we stuck with it, and we are still stuck with it, and we have not come to our senses around the appropriateness of this body in the midst of our society at the moment. And I'll just say around the lack of release of minutes from National Cabinet. That can only be justified if it is a cabinet. High Court said it isn't. And the whole status of bodies such as AHPPC, which have been designated as subcommittees of National Cabinet, which are the minutes have not been released, really worries me as a citizen. The reason I say that is I sat on AHPPC for 15 years when it was a COAG subcommittee, and every one of those meetings was subject to FOI, and we did release minutes to journalists, etc. So the absorption of AHPPC as a subcommittee of National Cabinet, and therefore somehow exempt from scrutiny and release of minutes, etc., is really problematic for me. So it's a pretty serious note to end on, but it's unresolved for me, and I think these kind of things come back to bite us if we don't sort them out from first principles. Thanks.
Thanks, Tarun. I might just ask everyone here to express your appreciation and provide a round of applause for Andy, Kerryn and Tarun. Fantastic observations and remarks and reflections, and that is where we'll leave our online audience. Thank you very much for joining us online or around Australia and overseas. For our regular participants, as you'll know, you'll shortly receive an evaluation survey in your inbox. Please take the time to fill it out. It's very useful for ANZOG and NRCoP to receive your feedback. The next NRCoP webinar will be held in Brisbane on Tuesday, the 28th of February. Yes, we're just about at the end of the year. It's going to be held before the ANZOG First Nations Public Administration Conference, and it will showcase positive examples of culturally responsive regulation from Queensland and the Northern Territory. Please join our socials, LinkedIn and Twitter, to keep up to date on all our events. And thank you very much for joining us online today. Thank you and all the best.